So, hello everyone. So, today we are going to have the second session of our 7th batch, and this session will be on neurology. Actually, it will take 3 sessions to complete the whole neurology. So, this will be the first part. And these are the prompts that comes from the neurology. There are several prompts like the dizziness, collapse, vision problem, transient weakness, tremor, headache, facial deviation, tingling and numbness, or unusual sensation, or paresthesia. These 8 prompts are the triple star prompts, meaning that they are the most important prompt. Then there are some double star prompts and some 1-star prompt. So 1-star means that they are not that much important, but they have come only 1 or 2 times in the last 4 years. And if you search in the history of PSS exam, you will rarely find any prompt that comes out of these prompts, these 20 prompts. So right today, we'll discuss the first 5 prompts. They are dizziness, collapse, vision problem, transient weakness, tremor, headache, and headache. These 5 prompts will be discussed in today's class. So let's start. So our first prompt will be on dizziness. So during my discussion or our discussion, if anyone have any kind of question, please feel free to stop me at that time. Or you can make a question at the chat box. I will back to you to meet your concern. So let's approach. Our first prompt is dizziness. Okay. So dizziness is a very much important prompt for PSS exam. And it comes every now and then. So actually, dizziness is a vague term. It is not a precise term. We have by this dizziness, it can be due to vertigo or spinning sensation, or it can be due to pre-syncope or lightheadedness. That can eventually lead to syncope. So by dizziness, we are not still confirmed whether this is vertigo or whether this is lightheadedness. So by our first question, we have to identify whether this is vertigo or pre-syncope or lightheadedness. So what would be the first question? The first question will be, what do you mean by dizziness exactly? Do you feel the whole world is spinning around you, or you felt like you are going to pass out? If the patient tells you that, yes, I was feeling like I was going to pass out, then the next question will be, did you lose your consciousness or did you pass out? If the patient tells you that, yes, I lost my consciousness, then the next question will be, for how long? We have to notice whether this is less than 1 minute or whether this is more than 1 minute. This is a very much important conception because only this duration can differentiate syncope from hypoglycemia or seizure. In the PSS exams, sometimes some cases are given where there will be no jerky movement, no tongue bite, no frothiness of mouth. Only the duration will be more than 2 minutes. In the PSS exam, whenever the duration is more than 2 minutes, every time it will be either hypoglycemia or seizure. Please keep it in mind. That is why if there is any history of loss of consciousness, we have to identify the period of loss of consciousness. That is whether this is less than 1 minute or less than 2 minutes. In case of syncope, it will be less than 1 minute. It will be typically within 15 to 30 seconds. So this will be the initial question. That what do you mean by dizziness exactly? Do you feel the whole world is spinning around you, or you felt like you are going to pass out? Did you pass out or did you lose your consciousness? So that will be our initial question to differentiate vertigo from lightheadedness. If the patient tells us that she is feeling the whole world is spinning around her, then this is vertigo. If the patient tells that she is feeling like she was going to pass out, then this is lightheadedness or pre-syncope, which can eventually lead to syncope. Please keep it in mind. So based on the information, we have to approach. So let's start from the lightheadedness or pre-syncope and syncope. Then we'll discuss on the approach to vertigo. Suppose the patient is telling you that, yes, I was feeling lightheadedness. I was feeling like I am going to pass out. Then this is pre-syncope. And the approach to pre-syncope and syncope will be the same. Now let's approach. So to remember the causes of pre-syncope and syncope, I have made a personal mnemonic that is NCP. All of you know there is a wonderful party in Bangladesh right now. This is NCP. I also term it, it can also be abbreviated in longer term like National Communist Party. Here, National goes for neurogenic causes. Communist goes for cardiovascular causes. And Party goes for postural hypotension. So there are some neurogenic causes of syncope where the causes of syncope is actually neurally mediated. There are some NAM involvement. Then there are some cardiovascular causes and there are some postural hypertension causes. So this goes for N, C, and P. So what are the neurogenic causes of syncope? The neurogenic causes of syncope are vasovagal syncope, subclavian still syndrome, carotid sinus hypersensitivity, and situational syncope. Let me explain one by one. In vasovagal syncope, what happens? Patient is in some kind of stress, like the patient is doing marketing in hot and humid climate, or the patient is sweating a lot, and suddenly or the patient is having some emotional excitement. So what happens due to this emotional excitement or excessive sweating? There is sorry, let me mute someone. Okay, so due to this emotional excitement, what happens? The vagus nerve becomes stimulated, and the vagus nerve has direct innervation to the AV node. Whenever the vagus nerve becomes stimulated, it directly inhibits the atrioventricular node. So in this way, the electrical passing through the AV node is interrupted and the cardiac output is decreased. Eventually, the patient becomes fainted. So this occurs in the vasovagal syncope. And before this episode, the patient typically feels nausea and some flashing sensation at the face and whole of the body. And typically, the patient will regain consciousness within 15 to 30 seconds. Whenever she lies down, she regains her consciousness. You will see many patients in day-to-day life, especially the female patients, whenever they become emotionally excited, they become faint. So this is vasovagal syncope. And there will be typical history of emotional excitement or working in hot, humid climate where there is excessive sweating happening. And before the dizziness or syncope, the patient will feel nausea and flushing. So this occurs in vasovagal syncope. This is very important cause for thesis exam. This comes very often. The next cause is subclavian still syndrome. So what happens in subclavian still syndrome? In broader term, if we think, this is our arch of aorta. From the arch of aorta, this is the brachiocephalic trunk, this is the carotid artery, and this is the subclavian artery. From the brachiocephalic trunk, also a subclavian artery arises. So suppose this is the subclavian artery on each side, one on the right side and one at the left side. So from this subclavian artery, two arteries arises. One artery gives blood supply to the posterior part of the brain, and another artery gives blood supply to the hand. It happens on both sides of our body, one on the right side and one on the left side. So what happens in subclavian still syndrome? Due to some causes, there happens to occur some stenosis due to some atherosclerosis, or sometimes due to some vasculitis, this part of the artery becomes squeezed. So this subclavian artery becomes narrower. So what happens when the artery becomes narrower? When the artery becomes narrower, the overall blood supply to this arteries become narrower. So one supplies to the brain. Sorry. This is our brain, and this is the hand. So overall, the blood supply becomes lower whenever there is proximal stenosis to this part of the subclavian artery. So at some point, whenever this hand starts to do activity excessively, this tries to drag blood towards it rather than to the brain. This tilts the blood from the brain towards the hand. Whatever small amount of blood pass through this area, this is dragged into the area of the hand. That is why the posterior part of the brain gets less amount of blood. And if we remember the neuroanatomy, there is a specific part inside our brainstem. That is the reticular formation. Forget about that. And this is actually responsible for maintaining the consciousness. So whenever the blood supply becomes interrupted, the reticular formation is also interrupted, and eventually the patient becomes faint. So this happens in subclavian Still syndrome. This has come one time in the Rawalpindi Center, that the patient was cooking in the kitchen. Suddenly, she was picking up something with her hand, with her left hand, and she got fainted. May I know, is it clear to everyone how the subclavian Still syndrome occurs? Is the pathophysiology clear to everyone? If it is okay, please give me a thumbs up so that I can proceed forward and I can make myself clear that everyone has understood. Any question from? Okay. Dr. Anwar has response, and okay. So this is another cause, that is subclavian Still syndrome. Before this subclavian Still syndrome, the patient will typically give a history of doing some activity with her hand. The next cause is carotid sinus hypersensitivity. So let's come to this cause. If we notice at our neck, there is an area where the bifurcation of the carotid artery occurs. This carotid artery becomes bifurcated at a certain level into the external and internal carotid artery. And around this bifurcation, there remains some nerve plexus. We called it carotid plexus. Why this is important? Because this carotid plexus has a direct connection with the atrioventricular node. So whenever we stimulate this carotid plexus, this can also stimulate the AV node. That is, it can also inhibit the AV node. Eventually, the patient becomes fainted. So with the progression of age, the carotid plexus becomes hypersensitive. With some small amount of stimulation can make it stimulated to a greater extent. Eventually, the patient feels dizziness, and then he can become faint, like syncope. So in here, the patient will typically give some history of manipulation at the neck, like the patient was shaving and suddenly he lost his consciousness. So that is carotid sinus hypersensitivity. Sometimes the patient can tell you that I was having some neck massaging at the salon or something like that. Sometimes the patient can tell you that I was wearing a tight collar. So that is carotid sinus hypersensitivity. And up to now, this case has not come in the PCS exam, but you can enumerate it as a cause. Then the next cause is situational syncope. This is also another neurally mediated AV nodal stimulation. So what happens actually, whenever we do some Valsalva maneuver, this also stimulates the vagus nerve. And whenever the vagus nerve is stimulated, the AV nodes is also stimulated. Eventually, the AV nodes become blocked. And whenever the AV node is blocked, the electrical supply from the atrium to the ventricle is interrupted, and the cardiac output is temporarily stopped or temporarily decreased. Then the patient will become fainted. So this is called situational syncope. We usually find these cases of situational syncope in case of like strain. Like the patient is having some constipation. And due to constipation, the patient needs to strain. And due to whenever we do straining, we stimulate the vagus nerve by, it is called Valsalva maneuver. And by stimulating the vagus nerve, we are blocking the AV node, and the patient will become eventually faint. Another thing is that due to some benign prostatic hyperplasia, during urination, patient have to strain. And due to straining, we can stimulate the vagus nerve by valsalva maneuver, which can eventually lead to syncope. We call it situational syncope. So these four are the neurogenic causes of syncope. How to rule each one of these, I will give you an easy technique, but give me some time for the time period. Then come to the cardiovascular causes of pre-syncope or syncope. Basically, there are two types of cardiovascular causes. One is due to outflow obstruction, and another is due to some abnormal electrical activity. We call it arrhythmia. So what happens in outflow obstruction? In outflow obstruction, ultimately the cardiac output is reduced due to some obstruction. And this outflow obstruction, I have divided it into two parts. One is outflow obstruction of the heart, and another one is outflow obstruction of the lung. If we remember the pathway of blood from the heart to the lung, from the lung to the heart, we'll see that the left heart gets blood supply from the lung. So if sometimes there is some obstruction of blood flow from the lungs to the heart, that can also lead to syncope. I'll give you some example. So let's start from the cardiological heart outflow obstruction. The causes of heart outflow obstruction are two. One is aortic stenosis, that is acquired outflow obstruction. Another one is hypertrophic obstructive cardiomyopathy. This is genetic. And in case of lung outflow obstruction, what happens? Due to some, whenever the patient is having some pulmonary hypertension, due to the pulmonary hypertension, the blood flow from the lungs to the heart is decreased. So eventually the heart will have less cardiac output that results in syncope. So it has come in the PCS exam 3 times. One time it came in Thiru with the prompt of syncope. The patient was having exertional syncope. Keep it in mind that whatever the cause of outflow obstruction, the patient will tell you that I had syncope while doing exertion, like running or jogging. Anytime any patient tells you that while running or jogging, I got fainted, then this is outflow obstruction until proved otherwise. This outflow obstruction can be from the heart or it can be from the lung. If it occurs from the heart, it will be aortic stenosis or hypertrophic obstructive cardiomyopathy. If it occurs from the lung, it will be due to pulmonary hypertension. This pulmonary hypertension can be due to primary pulmonary hypertension that came at the Thiruvananthapuram. Or this pulmonary hypertension can be due to secondary hypertension that due to some valvular heart disease like mitral stenosis. This has come also in the Pune this time, and the prompt was exertional syncope. And regarding the cardiac outflow obstruction, this is very much common and important cause because this comes every now and then. Whenever any patient tells us that in the PCS exam tells you that I got fainted while running and while auscultating, I'm finding that there is an ejection systolic murmur at the right triangle intercostal space radiating to the carotid. This is aortic stenosis. And in the differential diagnosis, we have to tell hypertrophic obstructive cardiomyopathy. So this is very much important cause for the causes of dizziness or syncope for the PCS exam. Please keep it in mind. Then another cause is arrhythmia. What causes arrhythmia in the heart? For the PCS exam, there are some defined causes. One is post-myocardial infarction. If you remember our first session, I have described what is the importance of the past medical history, track history, and family history. Because in the PCS exam, if you want to get your diagnosis earlier, in more than 80% of the cases, if you go to the past medical history, track history, or family history, you will get your diagnosis. This is my guarantee. So whenever any patient has past medical history of myocardial infarction, and right now the patient is complaining of dizziness, and sometimes the patient can have syncope, this is due to some post-myocardial infarction arrhythmia, maybe ventricular fibrillation or ventricular tachycardia. This can be due to some track-induced arrhythmia. Like sometimes the patient can take some medication that prolong the QT interval. In the PCS exam, this commonly comes with a past medical history, that is recent history of sore throat with intake of antihistamine. We all know that antihistamine prolongs the QT interval, and this can eventually cause arrhythmia. This has come in the PACES exam. Another cause is age-related. For the UK, any aged person, whenever they present with dizziness and sometimes syncope, we have to rule out arrhythmia until proved otherwise. We have to order first instant ECG. If nothing is found, we have to go for 24-hour Holters. That is 24-hour Holter ECG monitor. Eventually, if it does not found any cause, we have to proceed to the 7-day continuous ECG monitoring. It is written in the NICE CKS guideline. So it had come in the PACES exam. Any older patient, whenever comes to us with dizziness, we have to rule out arrhythmia. Then long QT syndrome and Brugada syndrome are another. There are congenital causes of arrhythmia. So typically, due to the arrhythmia, the patient will typically complain feeling of racing pacing of heart or palpitation just before feeling of dizziness and becoming faint. So this syncope will be preceded by palpitation. Just keep it in mind. I will explain why this is important. Okay, let me ask one question. The candidates who attended our last session, I had given a defined sets of questions that has to be asked during the past medical history, drug history, and also the family history. Can any candidate answer this question, that what is the important question to be asked in the family history to exclude cardiovascular causes of dizziness or syncope?
Sudden cardiac death?
Wonderful, doctor. Very good, doctor. Sudden cardiac death. Yes, doctor. Very good, doctor. It has to be asked. If we look back to the PDF file, we'll find it that family history of sudden death. We have to ask it during any case of syncope or palpitation. Please keep it in mind, because this case is very much common in the PACES exam. And this will come, this has come, and this will continue to come. Okay, thank you, doctor. So these are the cardiovascular causes of pre-syncope and syncope. Now let's come to the postural hypertension. To remember the causes of postural hypertension, I have prepared a mnemonic. The mnemonic is HANDS. Here H goes for hypovolemia, A goes for adrenal insufficiency or anemia, N goes for autonomic neuropathy, D goes for drugs, they are vasodilator, and S goes for steroid withdrawal. I have added, it can be also due to adrenal insufficiency due to the sudden steroid withdrawal. You can remember only hand or hands. So let me get one by one. The hypovolemia can be caused due to some loose motion or due to some vomiting. Then adrenal insufficiency. Adrenal insufficiency can happen due to primary adrenal insufficiency or secondary adrenal insufficiency. That is due to some pathology at the pituitary gland. But for the PACES exam, the postural hypertension, if the prompt is dizziness and the dizziness is due to some postural hypertension, every time it will be due to primary adrenal insufficiency. Never ever any secondary adrenal insufficiency has been given with the prompt of dizziness. If anytime any dizziness is given and that dizziness is due to postural hypertension, that will be due to primary adrenal insufficiency. This is the pattern of the PACES exam. Then another cause is anemia. We just have to ask the patient, do you think you are getting pale day by day? That will be the only question. Then N goes for autonomic neuropathy. Autonomic neuropathy can occur in case of long-term diabetes mellitus or in case of Parkinson disease with advanced disease or in case of Parkinson plus syndrome. In the case of Parkinson plus syndrome, it will appear from the very beginning. But for the PACES exam, only the diabetes is important. Then there are some vasodilator drug. There are alpha blocker, ACE inhibitor, or it can be due to diuretics. Then S goes for steroid withdrawal. We often find patient in the indoor department in the hospital that some patient is taking used to take steroid for a long period of time. Suddenly they withdraw the steroid, and eventually they come to the department with problem of syncope or dizziness, and the patient will typically complain that she is feeling dizzy standing from the sitting position. So these are basically the causes of presyncope and syncope. And wonderfully, these three causes can be excluded just by asking three sets of questions. What are the three sets of questions? The three sets of questions are, one set is before, another set is during, and another set is after. Among these three sets, the most important one are the sets of questions in the before. Because almost all of the cases, you will get your diagnosis just by asking these sets of questions in the before. And the questions are only two, simple questions, working and feeling. We just have to ask, what were you doing before this episode? And we have to ask, did you have any unusual sensation before this episode, like racing, pacing of heart, feeling sick or excessive hot, any smell or tummy discomfort? This is an aura which is found in case of seizure. So I would like to have interaction with the candidate. Can anyone tell me that if the patient tells you that before this episode, I was running, I was doing jogging in the morning, so what can be the probable cause?
Cardiovascular outflow
Yes, doctor.
obstruction.
Yes, outflow obstruction. Then if the patient tells us that I was doing marketing at the local supermarket, and it was a hot and humid climate, and I was sweating a lot. In the morning, I did not take the breakfast properly. So what can be? Very good, doctor. Vasovagal. If the patient tells you that before being faint or feeling dizziness, I was standing from the sitting position. What will be the posture? Postural. Have you seen how easy is this? It is very much easy, but it is very much important. Also, feeling is also important. Like in case of arrhythmia, before being faint down or before feeling the dizziness, the patient will feel complain of palpitation, like racing, pacing of heart. In case of vasovagal syncope, the patient will complain of feeling sick, that is nausea, and flushing of face, that is feeling of excessive hot. And smell and tummy discomfort is a type of sensory aura that is found in case of seizure. That is why only by asking what were you doing, how was you feeling, did you feel any unusual sensation, you will get your diagnosis in case of presyncope and syncope. Rest is you just have to act. So this is that much important. So after asking the before sets of questions, the next question is the during set. There are actually three questions. One question is, do you remember what happened during that episode? Because we have to identify whether this is true syncope or pseudo syncope. Sometimes the patient cannot remember what happened during that episode. This is true syncope. But if sometimes the patient can remember what happened during that episode, that is pseudo syncope. It is just a question. It is not important, but in the real life case, we have to identify whether this is a true syncope or whether this is a pseudo syncope. So to confirm that it is a true syncope, we have to ask this question, that do you remember what happened during that episode? Then we have to ask the question that any jerky movement, tongue biting, frothiness of mouth, soiling of clothes during the episode. After asking the question of soiling of clothes, we have to tell, I am sorry to ask that question because we are asking some personal question, that did you soil your clothes? This is to exclude the seizure. And for your kind information, I'd like to inform you that this jerky movement can also be there sometimes in case of syncope. This is not like that it will happen in case of seizure only or conversion. This can also occur in case of syncope due to some post-hypoxic anoxia. So only by checking the jerky movement and tongue biting and frothiness of mouth, we cannot differentiate syncope from seizure. The only point of differentiation I have told earlier is the period of loss of consciousness. If anytime the patient tells us that the loss of consciousness was less than 1 minute, this is syncope. And if the loss of consciousness is more than 2 minutes, it is hypoglycemia or seizure, unless proved otherwise for the PCS exam. Because what happened one time in the Delhi center that they gave a case of seizure. So the case was hypoparathyroidism. With the previous medical history of thyroid surgery, and the patient was having symptoms of hypoglycemia, and she presented with the complaint of seizure. There, the patient typically complained of no jerky movement, no tongue biting, no frothiness of mouth. Only there was loss of consciousness that was more than 2 minute time. So this is something like a non-convulsive epilepsy was there, non-convulsive, something was there, seizure was there. So only by checking the duration of loss of consciousness, we have to identify whether this is syncope or whether this is hypoglycemia or seizure. By checking the jerky movement and tongue bite, we cannot make it 100% confirm whether this is syncope or seizure, because this can also occur in case of syncope. Just keep it in mind. Then the next question is any change of color during the episode. Because in case of vasovagal syncope, due to some peripheral pooling of blood, patient becomes pale. But in case of seizure, the patient sometimes become blue, that is cyanosis. So just we have to ask any change of color during the episode. So these are the 3 questions we have to ask during the set. For the after sets of questions, there are also 3 questions. The first question is, how did you get back to normal? Whether this was spontaneously or by any sugary drink. This is to exclude hypoglycemia. Then, any confusion, headache, or limb weakness after this episode. This is to exclude post-ictal confusion. Then the last question will be, any injury following the episode. This is to ensure the safety. Because if the patient, after being faint, the patient can injure. And if there is any history of injury, we have to do some necessary intervention, like doing some CT scan or doing some other intervention. So the examiner in the PCS exam will clearly put his ear whether we are asking if the patient had any injury following the episode. So these are the 3 sets of questions. These are very much important. Among these 3 sets, the before set is the most important one. And by asking this working and feeling, we'll get our diagnosis. Is this clear to everyone? This is very much important. Please ask me this if there is any confusion or any question regarding this one. These 3 sets of questions. Or if there is no question, please give me a thumbs up reaction so that I can proceed to follow. Okay. So, let me tell you another one thing. The British examiner likes one approach. That is, whenever any patient comes with a complaint of loss of consciousness, the patient is likely that he or she may not describe the exact event that happened during that episode. So probably she has heard from her partner or from the person who was present there at that time. So what we have to do to prove as professional, we just have to ask tell the examiner, we just have to tell the patient that I would like to talk to your partner. Or the person whoever was present at that episode after our meeting today. Please keep it in mind. This is a very much important question to me to prove that you are professional. And if you ask this question, believe me, this will impress the British examiner that you would like to talk to the partner or the person who was present during the episode of loss of consciousness after this meeting. So this is all for the pre-syncope and syncope. Apart from this differential diagnosis, there is one unusual differential diagnosis that sometimes come in the PCS exam, and in the last 4 years, it has come 3 times. That is dizziness due to hyperviscosity due to polycythemia. And this dizziness is due to the lightheadedness. Sorry. This is not due to the vertigo. So this came one time. Let me check it. Okay. This came one time in Thiruvananthapuram. And the prompt was dizziness. Patient was having high blood pressure. And from outside, the hemoglobin was given as 19 gram per deciliter. And the patient was having symptoms of obstructive sleep apnea. So there was happening some polycythemia due to some obstructive sleep apnea that was causing hyperviscosity, and the presenting prompt was dizziness. And this dizziness is due to lightheadedness or presyncope. This came in the Thiruvananthapuram. Another time it came with at the Rawalpindi Center, the prompt was also dizziness, and the diagnosis was PSD with secondary polycythemia. This has also come in the Rawalpindi Center. The cause of dizziness is due to the polycythemia, which causes some sluggishness of blood in the anterior circulation. And this is actually lightheadedness. This is not the vertigo. And another time, this time in Kolkata Center, it came with the prompt of dizziness, and the patient was having atrial septal defect with pulmonary hypertension with secondary polycythemia. So every time the cause is due to polycythemia. This is some unusual cause. This comes very less often, but it has come. Just keep it in mind. Here the dizziness is due to lightheadedness, not due to something like vertigo. Just keep it in mind. So this is all for presyncope and syncope. That is dizziness due to presyncope or the approach to the syncope. Dizziness due to presyncope or lightheadedness or the syncope. Now let's proceed. Dizziness due to vertigo. How to approach to a case of vertigo. If from the initial question, the patient tells you that I'm feeling that the whole world is spinning around me, then this is vertigo. So how to approach to this vertigo? For this vertigo, first we have to analyze the symptom using the mnemonic ODPARA. What goes for ODPARA? If we look back into our PDF sheet, here the O means onset. That did it started suddenly or gradually. D means duration. We have to ask for how long you are having this kind of symptom. I means initial episode. We have to ask, are we having this kind of problem for the first time, or it's happening again and again? Then P goes for progression. We have to ask, does the symptom is the symptom gradually increasing day by day? Then A goes for aggravating factor, R goes for relieving factor. We have to ask, have you noticed anything increase or decrease your symptoms? Then A goes for associated features. We don't have to ask for any associated features right now. Then, after analyzing the vertigo using the mnemonic ODPARA, our second approach will be to identify whether this vertigo is constant or whether this vertigo is episodic. So how to identify this? We have to ask the patient, do you still feel spinning sensation? Or the spinning sensation just comes and goes? If the spinning sensation is constant, this is constant vertigo. The differential diagnosis is vice president of DMC. Here, V goes for vestibular neuritis, P goes for posterior circulation stroke, D goes for drugs such as phenytoin and gentamicin, M goes for multiple sclerosis, and C goes for CP angle tumor. So let's come one by one, how to screen for each. In vestibular neuritis, typically in the past medical history, the patient will give you a history of recent upper respiratory infection, like there is a history of recent sore throat. And if we remember the pathway, in our vestibular apparatus, there is a part called nerve and labyrinth. Whenever the nerve is inflamed, it is called neuronitis. Whenever the labyrinth is inflamed, it is called labyrinthitis, and there is a difference between both. Whenever the labyrinthitis happens, there is hearing impairment, meaning that the patient will have difficulty in hearing. But in case of neuronitis, the patient will not have any hearing impairment. Just keep it in mind to differentiate between the both. And the patient can also feel some tinnitus and numbness, some tinnitus sensation in the ear. And typically in the past medical history, the patient will give you a history of recent upper respiratory infection. That is why past medical history is very much important. Then posterior circulation stroke. In the posterior circulation stroke, typically in the past medical history, the patient will give you some history of risk factor like the diabetes, hypertension, dyslipidemia, or smoking. And remember one thing, whatever the cases of vertigo during the physical examination. I'm again repeating it. Whatever the causes of vertigo in the PCS exam, we have to rule out posterior circulation stroke during our physical examination. How to rule it out? Just by checking the finger nose test. Whenever we are doing the finger nose test, we are showing the examiner that we are ruling out posterior circulation stroke. Please keep it in mind. And this is the most important differential diagnosis to rule out in case of vertigo. Whatever the case comes in the PCS exam for vertigo, please keep it in mind. We have to rule out posterior circulation stroke during physical examination. Then the drug-related causes are phenytoin or gentamicin. You will typically find it in the drug history. In the multiple sclerosis, the patient will have cerebral involvement that will cause vertigo. To rule it out, in the screening question, we have to ask any episode of weakness, any previous episode of weakness. If the patient complains any previous episode of weakness, that is likely due to multiple sclerosis. Then the last is CP angle tumor. Any tumor, it will cause headache, and the headache will increase by coughing, sneezing, and bending forward. We just have to ask, do you have any headache? And is the headache increased by coughing, sneezing, and bending forward? So these are the differential diagnoses for constant vertigo. For the PCS exam, vestibular neuritis, posterior circulation stroke, and CP angle tumor are important because these are the cases which have come up to now. But keeping in mind all the other differential diagnoses so that anytime any cases come, you can cover this. But up to now, these three has come. Now let's proceed to the episodic causes of vertigo. That is, the patient will tell that my spinning sensation is not there all the time. It just comes and goes. So whenever this is episodic vertigo, the next thing is we have to identify whether this is triggered or whether this is spontaneous. If it is triggered, like during changing the head position from side to side while lying down, then this is benign paroxysmal positional vertigo. And this has come in the PCS exam. This BPPV has come. Another cause is postural hypotension. But the patient will typically tell you that during standing from the sitting position, I felt that spinning sensation. So that is due to the postural hypotension. There is impairment of circulation in the posterior circulation that is causing some vertigo. So this is triggered. And if there is no trigger, then this is spontaneous. In case of spontaneous vertigo, that is episodic, we will not find any trigger. One is the differential diagnosis, migraine and Meniere's disease. There is a specific type of migraine called the basilar migraine. So what happens in basilar migraine? The patient will not have any headache. The only presenting symptom will be this vertigo. That is why it is termed as basilar migraine. Keep it in mind. Then another cause is Meniere's disease. In case of Meniere's disease, typically the patient will be older and he or she will have some sensation of fullness inside the ear. That is called oral fullness. We just have to ask, do you feel any fullness of the ear to rule out Meniere's disease? So in this way, these are the screening questions. and the differential diagnosis of vertigo. So please ask me if there is any question regarding the approach to
Please repeat
vertigo.
about Meniere's disease.
Okay. In case of Meniere's disease, it occurs in case of older patient. And the patient will typically complain of feeling of oral fullness. That is sensation of fullness inside the ear. So how to rule it out? We just have to ask, do you have any sensation of fullness inside the ear? If the patient complies with that I feel feeling of fullness inside my ear, then this is Meniere's disease. And it will be episodic vertigo. Is it clear, Dr. Anwar?
Yes, sir. Okay.
Okay. So regarding this approach to vertigo, may I ask if there is any concern or confusion from any candidate? After that, I'm going to ask some real basis exam scenario from all the candidates. I will give you the scenarios and you have to tell me what will be the possible diagnosis. So any confusion up to now? Okay, I'm assuming that there is no confusion. So right now, I would like to have interaction from all the candidates. I will right now I will discuss some real basis cases that have appeared in the last 3.5 years. I'm going to give you the scenario, and you have to tell me what can be the probable diagnosis and what will be the important safety net. So, at one time a case came. It was a 65-year-old male with collapse. And after entering the station, the patient tells you that, yes, I was doing morning jogging, and while walking in the park, I just suddenly fell down. I just lost my consciousness. Then spontaneously, I regained my consciousness. This is not end. Let me tell you another thing. In the past medical history, the patient tells you that recently my GP diagnosed me as having a heart condition. Like I was feeling some chest pain and I went to my GP and he told me that I was having some heart problem. So that is the only past medical history he was telling. That is a heart problem. That was diagnosed by his GP. In the drug history, the patient complains that, not complain, in the drug history, the patient gives you the information that he is taking some medicine. Like one is penindropil, that is AC inhibitor. Another one is aminosalicylic acid or aspirin. Another one is isosolvite dinitrate. Along with PPI or omeprazole. So this is the information he got from the history, that the patient was jogging in the morning and suddenly he lost his consciousness. In the past medical history, he was diagnosed by a heart condition by his GP and he was prescribed this medication by the GP. So regarding this, first tell me what will be the probable diagnosis. Please, anyone can unmute.
Aortic
Yes.
stenosis and isosolvite dinitrate.
Yes, aortic stenosis. What will be the differential diagnosis?
Isosolvite dinitrate drugs.
No.
HOCM.
What will be the HOCM? Dr. B precise, because if you look at the mark sheet, you have to. It is very much important to understand the mark sheet, and I will discuss it also before starting of the practice session today. There is a mark for the differential diagnosis here. For any case of aortic stenosis, we have to tell the differential diagnosis is HOCM. So can you tell me what is the important family history we have to ask?
Sudden cardiac death.
Yes, sudden cardiac death. Okay, fine. Now let me ask you, what is the important safety netting?
Yes, to stop isosolvate dinitrate.
Very, very good, doctor. Stopping the isosolvate dinitrate. Because if you remember this question bank from the part 1 and part 2 scenario, I don't know, for some unknown reason, the GP in the UK setting, they are the culprit. All the mistakes are done by them. So they have made the mistake that they have started the medication thinking that this is a case of angina. Actually, this was a case of aortic stenosis. During walking, the patient was feeling some exertional angina, exertional pain, and the GP thought that this is due to some angina. And he started the medication thinking it as an angina. And this precipitated his heart attack, his syncope. So during history taking, we have to tell the patient that stop taking this medication, and I will talk to my consultant to replace this medication with some safer one, because this medication can increase this medication has a chance to increase your symptom. If you don't do the safety netting, it is 100% sure that you will lose your mark in the clinical communication skill. Please keep it in mind. That is why. Yes, doctor.
So this is to be discussed during history taking or during addressing concerns?
You can tell it during history taking or during addressing concern. But I will suggest that please, whenever you identify this culprit, tell it at an instant, because sometimes you may forget it during addressing concern.
Okay. Because during history taking, we may not have a diagnosis of aortic stenosis. So,
yeah, whenever you are doing the physical examination, you have found that this is a case of aortic stenosis. So actually what happens in the basis exam, in the exam scenario, there are a lot of stress sometimes there. So you may forget to tell this important part, that to stop that taking this medication. So whenever you are finding the aortic stenosis murmur during physical examination, it is better to tell the patient that stop that medication.
Okay, thank you.
Rather than waiting for the last part, because sometimes you may forget to give this important information that will carry at least 1 mark from both the examiner. Okay, this is one case. Let me tell you another case. This case came at Pakistan. So this was a 30-year-old female with collapse. I will also discuss the approach to collapse. Collapse actually means syncope, hypoglycemia, and seizure. So I'm discussing it because it is something related to the syncope. So after entering the station, from outside, the blood pressure was given as 150/90. So before entering the station, you will be given in a paper the name of the patient, the presenting complaint, or I call it the prompt, and some vitals of the patient. And sometimes you will find some clue from the vitals and the prompt. Okay. After entering the station, the patient typically tells you that I was cooking in the kitchen, and while taking something with my left hand, I just collapsed. So, can anyone tell me what will be the differential diagnosis for this case?
Subclavian syndrome.
Wonderful. That is wonderful. I have discussed this, but I want to hear any other differential diagnosis you can put this case.
Vasovagal.
Very good, doctor. Can you please explain why vasovagal?
Hot, humid environment.
Very good, doctor. Exactly, that was the case. This was the differential diagnosis for this case, and the patient was not having any pulse at her left hand. But we have to tell vasovagal syncope as the differential diagnosis because she was cooking in the kitchen, and at the kitchen, likely the environment will be hot. So we have to keep this differential diagnosis for this case. Okay. Now let me ask you another question that has also come in the basis exam. You will likely be able to answer this question, that a 70-year-old male came with dizziness. The prompt was dizziness. And after entering the station, whenever you ask that, what do you mean by dizziness exactly? The patient replies that, yes, I was feeling some spinning sensation. Likely that the whole world is spinning around me. So can anyone tell me, remember, what will be the next question?
What is the duration?
Okay, you have explained it using the mnemonic OD para. That is onset, duration, initial episode, progression, aggravating factor, relieving factor. All things are clear. Regarding the approach, what will be the next question?
Did you pass off or lose consciousness?
No, doctor. Actually, in vertigo,
Was it constant or episodic?
Yes, doctor. Constant or episodic? Okay. The patient replies you that it is episodic. It is likely, the professional way of asking this question is that, does it persist all the time or does it come and go? The patient tells you that, no, it does not persist all the time. It comes and goes. What will be the next question, doctor?
Associated with the change in position of your head.
Yes, doctor. What brought on that episode or what were you doing before that episode? The patient replies you that, yes, I was moving my head position in the bed. So I think you have got your diagnosis. What will be the diagnosis, Dr. Brevis?
So BPPV.
Yes, doctor, BPPV. So we have to ask that anything that increases your symptom, like before this spinning sensation, what were you doing? And this case has come in the PCS exam. Okay, let me ask you another prompt. These are real PCS exam scenarios, and you will get all the PDF sheet during practice. So this case, it was a 35-year-old lady. She came with a complaint of dizziness. So what she told that after entering the station, you're seeing that she is a short stature lady with some features of Cushing syndrome, some Cushingite appearance there is. And whenever you are asking, what do you mean by dizziness? The patient replies you that I was feeling like I was able to getting faint. And today morning, I had one episode of fits. Please keep it in mind. Today morning, I had one episode of fits. And whenever we are asking, what are you doing? What are you feeling? The patient replies that I was standing from the sitting position. That time I feel dizziness. And today morning, I had one episode of fits. In the past medical history, the patient tells you that I am a diagnosed case of cystic fibrosis. In the drug history, the patient tells you that I used to take steroid for some problem in my airway, but recently, due to some travel-related issue, I traveled to Australia. That is why I could not take my steroid. So, what will be your diagnosis, doctor?
Adrenal insufficiency.
Yes, doctor. Adrenal insufficiency. This is very much easy. Just by asking the before sets of question that what were you doing, what were you feeling, you will get your diagnosis. So can anyone reply me, what was the cause of fits in this case?
Postural hypotension.
Their fits means the seizure, like fits. Postural hypotension can cause syncope. And this is something different from the syncope. This is actually seizure. So what is causing fits to this patient?
Hypoglycemia.
Yes, doctor, hypoglycemia. Wonderful. Why this is important? Because whenever we are starting for physical examination for this patient, we have to offer to measure bedside blood sugar. If we don't offer this, we lose our mark in the physical examination. Is this clear to everyone? That's why I discussed this thing. Okay, let me ask you another question, another scenario. That is a 60-year-old man with recurrent dizziness. And here the dizziness, the patient tells you that I feel like I was going to pass out, but he didn't pass out. In the working doing, if you ask the before sets of question, the patient replies you that it occurs spontaneously. There is no particular time. Sometimes whenever I do gardening, whenever I do watching television, this occurs, this recurrent dizziness sensation. Then in the past medical history, the patient replies you that I have a past medical history of myocardial infarction. And I am taking, in the drug history, I am taking medication for that, that is ACE inhibitor. So what can be the diagnosis, doctor?
Arrhythmia.
Yes, post-MI arrhythmia. If in the past medical history, I also add diabetes, and in the drug history, I also add insulin to that. So in this case, can we add one more differential diagnosis for this?
So hypoglycemia.
Yes.
Autonomic neuropathy.
In autonomic neuropathy, the patient will tell you that I feel dizziness standing from the sitting position.
Yes.
Okay, doctor?
Yes.
So hypoglycemia can be one of the cause. So we can rule it out that how did you get back to normal? Did you take any sugar? If you notice the after set of question, it's there. This is the question. How did you get back to normal? Spontaneously or by any sugar eating? So these are some of the examples of the real cases scenarios. And this is all for the approach of dizziness.
Okay, I want to ask a question.
Yes, doctor.
As the patient is having ACE inhibitor, so
Yeah.
could it be drug-induced postural hypotension?
Yes, but the patient will reply you that I feel dizziness standing from the sitting position. The patient tells you that the dizziness occurs spontaneously during any episode, like whenever, sometimes while watching television, sometimes while doing the gardening. And even sometimes the patient may not describe you any feeling of palpitation. That is a hallmark of arrhythmia. Sometimes it may not be there.
Okay.
Are you getting it? So that is why the before set of question is very much important. Only by asking these two questions, you will get your diagnosis. And also keep in mind the unusual differential diagnosis for this dizziness. It has come 3 times. One at the Thiruvananthapuram, one time at the Rawalpindi, and one time at the Kolkata. This is due to hyperviscosity due to polycythemia. Okay, that's all for dizziness. Now let's go to the approach to the collapse. So may I ask if there is any confusion regarding the approach to dizziness? If there is no confusion, please, okay, Dr. Anwar has been responsive. Okay, now let us approach to the collapse. Collapse is something related to the syncope. So what does actually collapse mean? In the PACES exam, collapse means loss of consciousness. And this loss of consciousness can be due to syncope or hypoglycemia or seizure. So may I ask a question from the participant that how can you differentiate between the 3 causes? I discussed it in the previous problem. Can anyone reply this?
Duration?
Yes, doctor, duration. This is that much important. Only by asking the duration of loss of consciousness, you will differentiate between syncope from the hypoglycemia and seizure. If any time in the PACES exam, the loss of consciousness is less than 1 minute, it is syncope. If it is more than 2 minutes, it is either hypoglycemia or seizure. Please keep it in mind. Sometimes the jerky movement may not be there, or sometimes the jerky movement can be there in case of syncope. So only by seeing the jerky movement, you cannot become 100% confirmed whether this is syncope or seizure. The most important thing is to look at the duration of the loss of consciousness. So whenever the patient comes to you with a prompt of collapse, we have to ask that did you lose your consciousness, and if there is, for how long? Then we have to ask how many times did you lose your consciousness, and when was the last time? These are the initial questions we have to ask for any case of collapse. Then typically we have to ask that 3 sets of questions. They are before, during, and after. That we have discussed during the approach of pre-syncope or syncope. That is what you are doing. How did you feel any unusual sensation? Then during, do you remember what happened during that episode? During that episode, did anyone notice any jerky movement, tongue biting, frothiness of mouth, swelling of throat? And during the episode, I'm sorry to ask this personal question. Whenever you are asking some sensitive question like swelling of throat, please tell sorry to the patient. Then any change of color during the episode to differentiate vasovagal from the seizure. Then for the after sets of question, that how did you get back to normal? Spontaneously or by any sugary drink? Any confusion, headache, or limb weakness after this episode? Any injury following the episode? These are the sets of questions for the after. So the same questions will have to be asked for collapse. Then you will get your diagnosis. Let me tell you the causes of seizure. That is important for the PACES exam. In the PACES exam, typically 2 types of seizure comes. One is idiopathic, another one is secondary. And the secondary one is the most important one because this comes very now and then. The idiopathic causes comes very rarely. So what are the idiopathic causes? For the idiopathic causes, it can be the first episode or it can be due to some recurrence. These are very rare to come in the PACES exam. It has come only one time and this has also come in the one time. I have noticed in the last 3.5 years. That is why this is not that much important. But keep it in mind that whenever this is idiopathic, we are not finding any secondary cause. I'm discussing how to rule out the secondary cause. Whenever the cause is idiopathic and we are not finding any secondary cause, our job is to refer the patient to the seizure clinic within 2 weeks. This is our job as a registrar. Sorry, it will be not with, it will be within. So within 2 weeks, we have to ensure the referral of the patient to the seizure clinic. This is important for UK perspective. That is why whenever any patient comes to us with the prompt of with the complaint of seizure and there is no secondary causes found from the history and physical examination and investigation, we have to refer the patient to the seizure clinic within 2 weeks. Please keep it in mind. Sometimes one time a case came that was a diagnosed case of seizure, but it had recurrence. So what are the causes of recurrence? It can be due to missed medication, due to non-compliance. It can be the missed meal or missed sleep or flashing of light or stress. We have to rule each one out. We have to ask the patient, are you compliant with the medication? Any history of missed meal or any history of missed sleep or decreased sleep? Any history of flashing of light? How about your mood? This is to rule out the causes of recurrence. So this is the thing we have to keep in mind for idiopathic causes of seizure. And this is not that much important for PACES exam because this has come only 1 or 2 times. The most important causes are the secondary causes. So to remember the secondary causes of seizure, there's a mnemonic. The mnemonic is big monster invades daily. So here big goes for brain causes. Monster goes for metabolic causes. Invades goes for infection that can cause seizure. And daily goes for drug causes. Let me discuss one by one. Right now, I'm going to tell you that differential diagnoses that are important for the PACES exam that have come up to now. I'm not going to give you the whole list of differential diagnoses for the seizure. I'm going to give the definitive or very much important list of differential diagnoses you have to keep in mind for the seizure for the PACES exam. And that are due to some secondary causes. So inside the brain-related causes, one is intracranial space-occupying lesion. In the PACES exam, 2 types of case come. One is due to tuberous sclerosis. Another one is due to neurofibromatosis 1. So after entering into the station, you will typically find the facial rash of adenoma sebaceum for any case of tuberous sclerosis. For neurofibromatosis type 1, it will be easily evident by looking at the patient. You will find multiple neurofibroma. So after entering the station, if you find that the prompt is collapse, and after entering the station, you are finding that the patient is having some facial adenoma sebaceum, this is due to some ICSO. If you find that the patient is having multiple neurofibroma over the whole of the body, this is also due to some ICSO. That is nerve-forming tumor inside the brain. This has come in the previous exam in the last 3 and 5 years. Okay. Then another cause is post-stroke seizure. It has also come, and it will be evident from the past medical history. That if there is any past medical history of stroke, that stroke can cause some seizure. It has come in the Thiruvananthapuram. Then cavernous cerebral venous sinus thrombosis, not cavernous, cerebral venous sinus thrombosis. In case of cerebral venous sinus thrombosis or ICSO, typically the patient will have headache, and this headache will be increased by coughing, sneezing, and bending forward. And the cerebral venous sinus thrombosis is a disease related to the clotting problem. So, in the past medical history, the patient can give you some clue of having clotting disorder, like she can be a diagnosed case of systemic lupus erythematosus, and recently she had some loose motion or diarrhea, and right now she has come with the complaint of headache and 1 episode of fits or 2 episodes of fits, whatever that is. So this goes for cerebral venous sinus thrombosis. Sometimes the patient can complain of taking in the past medical history or in the female history, the patient can tell you some history of taking oral contraceptive pill, that is birth controlling pill. That is also a culprit for cerebral venous sinus thrombosis. So let me go back once again. Suppose any patient with cerebral venous sinus thrombosis, in the history, the patient tells you that I'm taking birth controlling pill. So if anyone attended the last class, can anyone tell me how to meet the concern or what we have to tell to the patient after that? Can anyone reply to this question? Like the patient diagnosis is cerebral venous sinus thrombosis.
Stop OCP, sir. Oral
Alternative
contraceptives.
contraception.
Yeah, that will be told by every candidate. But what will make you different from the other candidate? Like oral contraceptive pill is a jargon. You have to take birth controlling pill. But you have stopped the birth controlling pill. But have you offered anything alternative to the patient? Are you getting?
Yeah,
So woman
Refer to
doctor.
female doctor.
contraception.
Yes, doctor. We have to refer the patient to the woman doctor. Have you got it? Why this is important? We have to tell the patient that stop taking this birth controlling pill, and I am referring you to the woman doctor to offer you with some alternative one. That will prove you professional to the examiner, that you know how to approach to a patient who is taking birth controlling pill, and you have stopped the medication, and also you have ensured proper birth controlling by referring the patient to the women doctor, and it will ensure your mark in the clinical communication skill. All this is a matter of just making some impression to the examiner. We have to act like this. Then another cause is metastasis. It has come one time in the PCS exam as a cause of differential diagnosis. The prompt was patient came with collapse. And in the history, the patient tells you that the patient is a long-term smoker, and recently he is having loss of weight and loss of appetite, and he is having some unresolving pneumonia recently. So can anyone tell me, apart from, there's a one chance that there is a lung carcinoma that has metastasized to the brain, resulting in this conversion. What can be the other cause for this lung cancer patient that can cause conversion? Can anyone?
Hyponatremia.
Metabolic cause hyponatremia.
Yes, doctor, hyponatremia. That is another cause. And that was the differential diagnosis for that case. It has come in the PCS exam. That is why for the metabolic cause, hyponatremia is another one. Also, hyponatremia can be found in the PCS exam in case of CKD patient. Please keep it in mind. Advanced CKD patient can have hyponatremia. And actually, kidney cases are very much important for the Chennai Center. Because the Chennai Center has very frequently they give the kidney patients. So please keep it in mind. Whenever there is conversion and it's a CKD patient, it can be due to hyponatremia. I'll give you some real example. Then hypoglycemia is another cause. Hypocalcemia is another cause. It has come multiple times in the PCS exam, this hypocalcemia. I have already discussed with you that the Delhi case. It was a case of thyroidectomy. And whenever the case is thyroidectomy, and it is due to it is due to some incidental parathyroidectomy, typically the patient will some handkerchief around her neck. It will happen. It happened in the Delhi center. The lady was having some handkerchief around her neck, so that you will not be able to identify the scar mark unless you remove the handkerchief. And also this happened this time, in this diet, the Dhaka center. The prompt was hand weakness, hand pain, and the cause was hypocalcemia. I discussed the approach to hand pain in the previous class, and what I want to tell that this hereditary patient usually enclose some handkerchief around their neck to hide the scar mark. So unless you ask the past medical history, you will not get your diagnosis. That is why I tell again and again, this past medical history, drug history, and family history is very much important. If you want to get your diagnosis earlier, just after symptom analysis, go to this past medical history, drug history, and family history. In more than 80% of the cases, you will get your diagnosis. This is my guarantee. Sometimes it will be 100%. And there will be so much information inside this past medical history, drug history, and family history. You cannot imagine how much information you will get inside this past medical history, drug history, and family history. And for this past medical history, drug history, and family history, I will suggest you to memorize these sets of questions. That what are the questions we have to ask this past medical history? Because unless you ask this specific question, that any surgery before, the patient will never give you the answer. This happens in the PCS exam. Until you ask that any recent procedure, the patient will never give you the right answer. Let me give you an example. I have also discussed in the last session that whenever I appeared at my exam, my case was a meningitis. And I asked, do you have any past medical condition that I should be aware of? The patient typically didn't. Whenever I asked that, do you have any surgery before? Then the patient replied that, yes, I had a road traffic accident 5 years back, and during that time, some part of my tummy, inside my tummy, had been removed. He was not telling what was the name of the surgery. So right after that, I removed the gown by taking the permission, and I found out that there was a splenectomy scar. So unless I asked any surgery before, he would not give me the right answer. Then another thing is any recent procedure. Let me give you an example. One candidate got a case of fever, and he was not getting any clue. He was asking all the questions in the past medical history, drug history, and family history. No clue was there. Just right before ending of the time, he had 2 minutes left. He asked any recent procedure, and the patient replied that I had some dental procedure, the 1.5 months back. So whenever in the PCS exam there is history of dental procedure, this is infective endocarditis unless other proved. So that is why I will suggest you to memorize these 8 questions by heart. Because in the exam, you don't have proper time. You will not have enough time to think and then reproduce. And also it goes for the drug history. And in the drug history, medication allergy is very much important. Please never forget it. It may not have any clue or any relation to your actual diagnosis. But the examiner will see whether you are identifying any important allergy to the medication. It has come in the PCS exam multiple times. Also during the Diet 3 exam, one of my candidates who appeared at the Delhi center, his case was loose motion. And he was asking any allergy to any medication. The patient replied that 5 years back, I had one episode of upper respiratory tract infection. And during that time, I took some penicillin, and that caused some reaction. It had nothing to do with the real diagnosis. But he was the only candidate at that carousel who could identify this allergy to this medication. And this has also happened during recent time in the Hyderabad center. The patient was giving history of allergy to the penicillin. So these are the important questions. And if you will get your diagnosis in more than 80% of the cases, if you go to the past medical history, drug history, and family history, right after symptom analyzing, instead of going to the systemic review. Okay. So another cause of metabolic causes of is renal failure. I will give you some real example. And hypertensive encephalopathy. Don't worry, it will become easier to memorize or to keep it in mind if I give you some real example. The inverse cause infection. Infection is up to now, no infection related cause has come up to now as a cause of seizure. So for PCS exam, you can skip it. Then there are some drug causes. One is cocaine, another is alcohol withdrawal. This both has come in the PCS exam. And these causes are important on perspective of UK, not for India and Bangladesh. Okay, these are the causes of secondary causes of stroke. That is brain-related causes, metabolic causes, and drug causes. Among the brain-related causes, some are due to ixal and cavernous venous sinus thrombosis or metastasis. We can rule it out just by asking, do you have any headache that is increased by coughing, sneezing, and bending forward? It can be the post-stroke. It will be evident only by asking the past medical history. Regarding the metabolic causes, hyponatremia is important. In the PCS exam, it has come with the prompt of lung cancer, with the symptoms of lung cancer that is causing some hyponatremia like small cell lung cancer. Hyponatremia can also occur in case of advanced CKD patient. These two types of cases have come up to now. Hypoglycemia can cause seizure. Hypocalcemia can cause seizure, also with renal failure and hypertension. And regarding the drug-related causes, alcohol withdrawal and cocaine is important. Okay, so let me ask you a question. Regarding the seizure, whenever any seizure comes in the PCS exam, we have to stop the driving, and whatever the case is, we have to do this important safety netting. That is, avoid hobby like cycling and swimming. Avoid heavy machinery and sharp cutting object. And don't close the door during taking bath. This is also important for your communication station. If you don't do this important safety netting, you will lose your mark. In the clinical communication skill. Please keep it in mind. So please get it by heart. What are the important safety netting we have to tell to the patient whenever any seizure comes in the PCS exam. Now let me ask you a question. Suppose this case is coming in the PCS exam. A 45-year-old male has come with collapse. And after entering the station, you're finding out that this is due to something seizure. He had loss of consciousness for more than 2 minutes and he was having some jerky movement. In the past medical history, the patient tells you that I'm a diagnosed case of kidney disease and I'm undergoing dialysis for that. And right now the patient has come to you with some complaint of convulsion. So before asking about the differential diagnosis, okay, let me ask you, what would be the differential diagnosis? From the outside, the vitals are given, the blood pressure is 180 by 110.
So dialysis disequilibrium syndrome, hyponatremia.
Yes, doctor. Anything else?
Uremic seizures.
Wonderful, doctor. Anything else? And the cause of diabetes was long-term, the cause of CKD was long-term diabetes mellitus, and he was taking insulin. Sorry, I missed this information. So can you add any more differential diagnosis?
So hypoglycemia.
Hypoglycemia.
Yes. So you have got 4 DD. One is dialysis disequilibrium syndrome. Another one is uremic encephalopathy. Another one is hypoglycemia. So anything else, doctor?
Hypertensive encephalopathy, sir.
Very good, doctor. Hypertensive encephalopathy. Then what will be the 5 causes? 5 causes.
Press.
Yes.
Infection, sir. Infection also. Patient is undergoing dialysis.
Yes, but there is no fever. Yes, infection can also cause dialysis.
Electrolyte imbalance, sir. Electrolyte.
Yes, doctor. Electrolyte imbalance. That is hyponatremia. And that was the diagnosis. At least these 5 differential diagnoses we have to tell. Are you getting it, doctor? Why this is important? And this is actually very much important for the candidates who is appearing in the Chennai Center, because Chennai Center has all of the kidney cases there. And is it clear to everyone? And whenever we are starting for examining any conversion patient, our first step will be to measure bedside blood sugar. Whatever the case of cause of conversion is, always start by offering to check the bedside blood sugar, because hypoglycemia is a very important cause of seizure. Please keep it in mind. So this is all for the approach to collapse. Now let me ask you if there is any question from this prompt.
Sir, I'm not getting about that first episode referred to seizure clinic, because if the patient comes, then we have to admit him. I mean, then wait for 2 weeks. I'm not getting that, sir.
Okay, let me see. If the episode of seizure is for the first time, and this is occurring for the one episode, it is not necessary that we have to admit the patient. Because whenever anyone is having some epilepsy and he is having seizure only for one time, there is no indication of starting any medication right now, unless there is recurrent episode of seizure. And that decision will have to be taken by the neurologist. It is not my job. So any patient has come to you with one episode of seizure and you have not got any secondary causes. So right now, your job is to refer the patient to the seizure clinic. And that referral we have to ensure that the patient has to attend the seizure clinic within 2 weeks. Are you getting it, Dr. Anwar?
Yes, sir.
And
Yes.
and what about the safety netting in case of first episodes of seizure? Should we?
Same. Any seizure, we have to tell like this. It will keep us in the safe side.
Okay.
Any seizure, tell this safety netting. And this is the simple thing. Look, what happened in the PACES exam. PACES exam is not a difficult one. It is very much easy and doable exam. Once you understand how to get the right thing, it is very much easy exam. And most often the candidates make mistakes in simple and easy skill. It is not like that they have missed some wonderful diagnosis, some difficult diagnosis. That is completely wrong. In the PACES exam, difficult cases comes very, very rarely. They want to know whether we are a safe doctor or not, whether we are able to perform there at ST3 level as a registrar. They are not assessing us as a consultant. And we will get all the time the support from the consultant whenever necessary. Like I can give you some example. What I'm telling you that in the PACES exam, they don't judge the knowledge to that much. So whenever in the clinical judgment, only 2 sets of questions are very much important, you have to know. One is investigation, another one is management. So I got a case in my time that was meningitis. And in the cross-questioning, the British examiner asked me that what antibiotic you would like to choose for this patient. It was a case of splenectomy. So probably due to some encapsulated bacteria, he was having some meningitis. So I told the examiner that right now I cannot remember the name of the antibiotic, but I would like to talk to the infectious disease department to take their comment. What will be the right antibiotic for this patient? The examiner was okay, and I got full mark. So this is the way things happen in the UK. It is not like that they have to memorize all the things. Whenever we are not getting any information, we can take help from our senior or from the respective department. This thing is also important for the communication station that is not related to the long clinical consultation. Let me give you another example. I got a case in the communication station that was insulin overdose. Iatrogenic insulin overdose, where the patient was admitted into the hospital. So the surrogate was telling to me that whenever I used to take this medication at my home, I was not having any kind of episode like this. So it is completely your fault. Okay, I just apologize for this. So right after that, the surrogate told me that I want to take this medication right now with my own. I don't want to rely on you. So give me the permission to take my medication on my own. So I'm not working right now in the UK. So I don't have the idea whether this is allowed in the UK or not. So how I met that concern, I just told the surrogate that regarding this concern, I don't have the proper information right now, but I'll go back to my senior and I will get back to you after getting the right information before you leave the room. The surrogate was okay, and I got full mark in the communication station. So after that, this is how thing happens in the UK. I think this is clear to all. So this is all for seizure. So if it is clear, let me proceed to the next prompt, that is vision problem. This is also very much important for the PACES exam. Very, very much important. This is a triple star case. This comes every now and then. So actually, vision problem can come in the PACES exam with three types of problem. Like it can be due to double vision, or it can be due to sudden loss of vision, or it can be due to gradual loss of vision. Whenever any case comes in the PACES exam with sudden loss of vision, it will be transient loss of vision. Keep it in mind. It will be nothing like that, any retinal detachment or vitreous hemorrhage. Because just think yourself, you are working there as a medicine register. Will not be given such cases which have to be dealt with some ophthalmologist. So any sudden loss of vision will be there. After entering the station, after taking the history, you will find that this was a transient loss of vision. I will discuss one by one. So the prompt from the outside can be given in any form. It can be given as the prompt of vision problem, like Mr. Jacob has come to you with the problem of vision. Or it can be given to the direct symptom that Mr. Fernandez has come to you with a complaint of double vision. Or it can be given, he has come to you with a complaint of transient loss of vision or gradual loss of vision. So any type of prompt can become. So vision problem is a broader term. By vision problem, it can be due to double vision, it can be due to sudden loss of vision, or it can be due to gradual loss of vision. So how we have to approach? If the prompt is vision problem, like in the outside, the prompt is given that this patient has come to us with the complaint of vision problem. First, we have to identify what type of vision problem he is having. How to identify this? We have to ask the patient, what do you mean by vision problem exactly? Is it double vision, or loss of vision, or blurring of vision, or difficulty in seeing the sights, or problem in night vision? We have to give some example to make it identify what type of vision problem he is having exactly. Then, if the patient tells you that he is having double vision, now let's discuss the approach to double vision. Whenever any double vision comes, first we have to confirm that this is actually a double vision. So we have to ask the patient, what do you mean by double vision? Do you see two images of a single object? The patient will typically reply with that, yes, I see two images of a single object. So this is actually a double vision. The next question is to differentiate monocular double vision from binocular double vision. This is very much important question for double vision. If you don't ask this question, you lose mark in the clinical communication skill. Why this is important? Because the question is, when you close your one eye, does the double vision disappear? In the PACES exam, 100% time, the double vision will be disappear because it will be binocular double vision, not monocular double vision. So do anyone have any idea what is binocular double vision and what is monocular double vision? Or should I discuss the pathophysiology of this?
Due to squint, there will be binocular double vision.
Actually, doctor, it is something beyond that. Okay, let me discuss it. It will be better for everyone. Suppose these are eyeball. These are eyeball. Sorry, eyeball is not good. This is eyeball. And this is another eyeball. And this is the occipital cortex. So what happens? From this eyeball, the rays come to a particular site of the occipital cortex. And also from the other eyeball, the rays come at that particular site of the occipital cortex. So we see one object. This is the reason we see one object, because the ray from both eyeball coincides at a particular site of our occipital cortex. That is the reason we see one object. But sometimes, suppose due to some problem, like some problem in the extraocular muscle, the eyeball is misaligned, like the eyeball cannot move to the right or to the left. And what happened at that time? The ray, instead of approaching in this way, the ray has bypassed in this way. And what is happening right now? From this eye, the ray is merging, the ray is happening at this side, but from this eye, the ray is coming at this side. So there are basically two sides on the occipital cortex. This is occurring due to some problem in the extraocular muscle, or due to some nerve-related problem. The eyeball is not being able to move in the right direction, so that the eye ray, the ray coming from the eye is not merging at a particular side. That is why the patient is seeing double. Please tell me if it is clear to everyone.
Yes, sir. Due to neurological cause, there will be binocular.
Anything like that. Yes, it can be neurological cause. It can be, in broad term, it can be any medical cause.
Okay.
But what happens if there is some problem inside this eyeball, like some refractory error due to some problem in the lens, or some problem inside the vitreous humor or aqueous humor that is causing some refractory error? At that time, the patient can also have double vision. Please tell me if it is also clear or not. I'm telling you once again. Due to see this muscle-related problem or nerve-related problem, the eyeball cannot move to this side or this side in the proper way. That all the movements of the eye is not doing in a right manner. That is why whenever one ray is coming from this eye is marching on this, is happening on this side, the ray from this eye is falling on this part of the brain. So the patient is seeing double whenever he is trying to see with both eyes. But what happens whenever this eye is closed? Suppose this eye is closed, you are closing this eye. What will happen right now? Will the patient see double or single? Please tell me.
Single.
Single. So, but whenever we are removing the eye, we are removing the occlusion of the eye, will the patient see double or single?
Double.
Yes, doctor. So, whenever we are closing one eye, the patient, the double vision will disappear. But whenever we are removing the occlusion, the double vision will reappear. But suppose the patient is having some problem inside the ear, inside the eye, and you are occluding this eye. So what will happen right now? Will the double vision disappear?
No.
Why?
It is due to refractive error in the eye.
Yes.
That is problem.
Yes, doctor, exactly. So this is due to some problem inside the eyeball. That is ophthalmological causes, and that is not our deal. Are you getting it? Why this is important? We will be given case which have medical causes, not ophthalmological causes. Whenever the double vision disappears after closing one eye, this is medical cause. But at each time, if the double vision does not disappear, even after closing of one eye, this is some ophthalmological causes. And this is not our deal. This will be dealt by the ophthalmologist. And this will never be given in the PCS exam. But the examiner will see whether you are excluding monocular double vision from binocular double vision. That is why this conception is very much important. Please tell me if this conception is clear to each and everyone. If this is not clear, I'm ready to repeat it once again. Yeah, Dr. Anwar is clear. Dr. Shagor, is it clear to you? Okay, Dr. Sumaya has been clear. Dr. Kia, is it clear to you? Okay, Dr. Salma has requested to make it repeat once again. Okay, I'm repeating. Don't worry, doctor. I'm ready to repeat it thousands times. Okay. Suppose this is one eyeball and this is another eyeball. And this is the occipital cortex. So how we see an object? What happens inside our brain and inside our eyeball? So there happens, ray from this eye comes to fall on this part of the occipital cortex, and rays from this side also falls on the same part of the occipital cortex, so that they merge on the same side at occipital cortex. That makes us see one object. That is the reason we don't see two objects. But what happens if for some reason the ray from this eye, instead of falling at this part, the ray is going in this direction? So right now what has happened, the ray from this eye has fallen on this part of the occipital cortex, but the ray from this eye has not fallen about the same part. Eventually, the patient will see double. And these things has happened due to some causes, due to some problem in the extraocular muscle, or due to some nerve-related problem that is responsible for the movement of the extraocular muscle. So this is a double vision. So what will happen? Suppose this is the case, and Dr. Sharma, I'm just asking you. So suppose you are closing this eye. What will happen right now? Will the patient see double?
No.
Yes, doctor. Very good. So let me tell you another case. Suppose this same man is having some problem inside the eye, like some refractive error. Inside the eye, there may be multiple problems. This is not of our deal, but due to some problem inside the eyeball, the ray can also become distracted. Instead of falling this point, this can fall in this point. So this is due to some problem inside the eyeball. So suppose the patient is seeing double due to some intraocular refractive error. And right now, you have occluded this eye. So what will happen right now? Will the patient see double or single?
Single.
No, doctor. The patient will see double because there is problem inside the eyeball.
Okay.
Are you getting it? Is it clear, doctor?
Yes.
So whenever the double vision disappears by closing one eye, it is binocular double vision. But if the double vision remains there, even after closing one eye or alternate eye, this is monocular double vision. And monocular double vision is a case of ophthalmology. It is not our deal. In the PACES exam, we will be given binocular double vision. We know that we have been given a binocular double vision, but we have to show the examiner that we are proving it. We have to ask the patient that when you close your one eye, does the double vision disappear? This is very much important conception. I think this is clear to all right now. Then the next question will be, when did it start? Did it start suddenly or gradually? And is it the first time? Just keep a look at this. This prompt cannot be analyzed by ODPARA. This has to be analyzed by this question. That is why during our first session, I discussed that not all the prompts can be analyzed by ODPARA. It can be analyzed, 90% of the prompts can be analyzed by the ODPARA. But there are some prompts which cannot be analyzed by ODPARA. And what will be the initial questions for that prompt? I will give you a written sets of questions in the recording. And like this one. This will be the question for double vision. Now next, you can directly go to the differential diagnosis of double vision.
Sir, I have a question here.
Yes, doctor.
So when we ask that when you close your one eye, does the double vision disappear? So do we have to ask when you close your affected eye, or you just have to close one eye, any of the eye?
One eye, any of the eye.
So sir, in the refractive error, when you were explaining, suppose we cover the refractive error eye, so there won't be a double vision.
Yes, doctor.
So
that is why I am not telling the affected eye, I am telling one eye.
Okay.
Are you getting it, doctor? I'm telling that whenever you are closing your affected eye, the patient does not know which eye is affected. I have just asked, whenever you close your one eye, does the double vision disappear?
Okay.
Okay, doctor. Thank you for asking that question. Now let us go to the differential diagnosis of double vision. The differential diagnosis can be first two Graves. One is myasthenia gravis, another is Graves' disease. Then nerve palsy, one is sixth nerve palsy. This can be unilateral sixth nerve palsy or bilateral sixth nerve palsy. For basis exam, unilateral sixth nerve palsy is important. Bilateral sixth nerve palsy has never come up to now. Then another cause is third nerve palsy. This third nerve palsy can be due to medical related causes or surgery related causes. Up to now, it has come only one time, which is due to some medical related causes. So can anyone tell me how to differentiate medical causes of third nerve palsy from the surgical causes of third nerve palsy? I have explained it in the physical examination video. You will get it as a recording. But let me ask it right now to the active participant.
By pupil examination?
Yes, doctor, by pupil examination. By pupil examination, you can differentiate surgical from the medical causes. Then 3-4-6 nerve palsy is there. How to differentiate third nerve palsy from 3-4-6 palsy? It is explained in detail in the physical examination video. In the physical examination video, you'll also find a specific thing for this case, that how to approach to a case of ptosis and how to examine the cranial nerve. You will be given as a flowchart there. And this is very much important. This is also important for a short case station. Then another cause is internectar ophthalmoplegia and Wernicke's encephalopathy. For PACES exam, the first three causes are the most important one. For UK, Wernicke's encephalopathy is important. You can keep all the things in mind, but the most important one are the 1, 2, and 3 causes. That is myasthenia gravis, Graves' disease, and sixth nerve palsy. So right after entering into the station, you'll get your diagnosis. After entering the station, if you see that the patient is having some drooping of eyelid, and the drooping is something asymmetrical, this is myasthenia gravis. If you find that the patient is having some neck swelling, that is goiter, this is Graves' disease. If you find that one of the eyeball is deviated to the medially, this is sixth nerve palsy, and it is unilateral. We have to ask the past medical history whether the patient is having any risk factor like diabetes, hypertension, or something like that. We have to also rule out vasculitis. And Wernicke's encephalopathy is important for the UK center. It has not been given up to now at any Indian center, not at Dhaka center also. And for any case of vision, double vision, we have to stop driving. Please keep it in mind. So this is all for double vision. Please ask me if there's any question regarding the approach to double vision. If it is clear, please give me a thumbs up so that I can proceed forward.
So what is the significance of asking, is it the first time?
For this case, okay. For this case, it is not that much, sorry.
Only for the transient loss of vision only, sir, we can ask that now.
Actually, doctor, yeah, it is not that much important. But for any prompt, it is not related to the diagnosis. But for any prompt, we have to ask this question, whether this is occurring for the first time or not.
Okay.
But
so can it be related to multiple sclerosis?
Multiple sclerosis patient in the form of internectar ophthalmoplegia can have double vision. Yes, doctor. We can relate it to it. Good, doctor. Wonderful. But up to now, this case is very rare, keeping in the PACES exam. But you can keep it in mind because sometimes it can be given as a rare scenario. Is it clear, Dr. Babies? Dr. Anwar has given a wonderful example that multiple sclerosis patient can be given with the prompt of internectar ophthalmoplegia.
Yes, sir. Because you initially you told us that we don't have to follow OD para for double vision.
Yes.
So that's why I asked you, is it for the first time do we have to follow here? That's why.
Yes, doctor. Thank you for asking this question. Now let me tell you a way to remember the features of myasthenia gravis, because myasthenia gravis is a very much important case for PACES exam. There's a particular pattern at the PACES exam. What is the pattern? The pattern is sometimes they shuffle the short case with the long case. like at the first day of first carousel, this myasthenia gravis patient can be given at the short case station with a prompt of examine neurologically. But at the same time, during the second day, third carousel, this myasthenia gravis patient can be given as the prompt of double vision or dysphagia or fatigue. So that is why it is important to remember the features of myasthenia gravis. I have a wonderful mnemonic for that. That is the rule of D. So what is the rule of D? Starting from the eye. At the eye, there are two D. One is drooping of eyelid. Another is double vision. Then at the mouth. At the mouth, there is also 2D. One is dysphonia. In myasthenia gravis, there can be involvement of bulbar involvement that can cause dysphonia. And this can also cause dysphagia. At the chest, the patient can have difficulty in breathing. And this is the most important thing we have to rule out as complication. So it is another D. At the arm, we have to ask for difficulty in combing hair. Then also, we have to look at the drug history. Can anyone tell me what is the importance of looking at the drug history here?
It triggers the
Yes, triggers. Then, if there is double vision, we have to stop driving. And last, we have to offer medic alert bracelet. So that is the rule of D. It is the kingdom of D in case of myasthenia gravis. I have termed it rule of D. Is it clear to everyone how to remember the features of myasthenia gravis? From the eye, it is drooping of eyelid and double vision. At the mouth, it is dysphonia, that is voice change, and dysphagia, that is swallowing difficulty. At the chest, it is difficulty in breathing. At the arm, it is difficulty in combing hair. Then we have to take the drug history carefully. We have to stop the driving if there is double vision, and we have to offer medical alert bracelet to the patient. And this is all called double vision. So if it is clear, let me progress to the next prompt, that is sudden loss of vision. So may I proceed to the second prompt? Any confusion from this double vision? Do anyone have any kind of confusion from this double vision? May I know? Okay. Let me assume that there is no problem. Now, let's proceed to the sudden loss of vision. Whenever in the PACES exam, the prompt is sudden loss of vision, every time it will be transient loss of vision. And it will be evident after you take the history. Because for the PACES exam, one of the two most favorite cases are, one is TIA, another one is amaurosis fugax. These are very much common cases in the PACES exam. And 100% time, this will be surrogate. This will be dummy case. So in the physical examination, you will not find any positive physical finding. And whenever you are not finding any positive physical finding, don't synthesize anything. Because if you synthesize anything, you lose your mark in the identifying physical signs. So let me approach to the sudden loss of vision. So regarding the sudden loss of vision, also these are the initial questions. We have to ask, when did this occur? Okay, let me tell you. For the PACES exam, any transient symptom like transient loss of consciousness or transient loss of vision or transient weakness, we have to ask these three sets of questions. That is before, during, and after. This is mandatory for every transient symptom occurring in the PACES exam. This can be transient loss of vision. This can be transient loss of consciousness, or this can be transient weakness. So what will be the question? The first question will be, when did it occur? Did it occur suddenly or gradually? Is it the first time? Did it affect one eye or both eye? Whether this loss of vision is one eye or both eye. And typically it will be one eye. Then do you still have the vision problem right now? Then we have to ask, what were you doing before this loss of vision? How long the episode last? And how did you get back to normal? This is very much important because one of the most important differential diagnosis of amaurosis fugax for the PCS exam is hypoglycemia. And by asking this question, how did you get back to normal? Did you take any sugary drink? You are ruling out hypoglycemia. Now let's get back to differential diagnosis. This is the mnemonic. The mnemonic is so many good guys. Here, so goes for stroke, that is eye stroke, also called amaurosis fugax. For many, it is migraine and multiple sclerosis. In the migraine, sometimes there can be some aura. That aura can be in the form of loss of vision. In the multiple sclerosis, due to some optic neuritis, the patient can have sudden loss of vision. For good goes for glucose, that is hypoglycemia. And guys goes for giant cell arteritis. Giant cell arteritis can also affect the optic nerve that can cause some sudden loss of vision. So how to rule the differential diagnosis? What will be the screening question? For amaurosis fugax, we have to ask, did you felt like any curtain coming down over your eye? It will be like some curtain coming down. That is the hallmark question of amaurosis fugax. Please keep it in mind. Sorry, let me write it. It will be feeling like curtain coming down over the visual field. We have to specifically ask the patient, did you felt like some curtain was coming down? So this will be the screening question for amaurosis fugax. Then for migraine, we have to ask, did you have any headache after this loss of vision? For multiple sclerosis, we have to ask, any similar episode of weakness previously to rule out multiple sclerosis. Or we can also ask, any painful loss of vision, because in case of multiple sclerosis, there will be optic neuritis that will cause painful loss of vision. So any painful loss of vision, any previous episode of weakness. This will be the screening question for multiple sclerosis. For hypoglycemia, we have just can ask that, did anyone measure your blood sugar during that time? For giant cell arteritis, we have to ask, do you have any headache at the side of your head? That is at the temporal region. And so these are the differential diagnoses for sudden or transient loss of vision. And for any sudden or transient loss of vision, we have to stop the driving. So this is all for sudden loss of vision. Please ask me if there is any question from this prompt. So Dr. Raisa, do you have any question?
No.
Okay, Dr. Kia, any question from this prompt? Any confusion?
Can you please again tell the before, during, and after questions?
Okay. Here the before question will be, what were you doing before this episode? Only doing, not feeling. For the during, we have to ask how long the episode lasted. It will be typically 3 to 4 minutes. Then for the after, we have to ask, how did you get back to normal? Did you take any sugary drink to rule out hypoglycemia? Is it clear, Dr. Taji?
Yes, thank you.
Okay, you are most welcome. Please, if anyone have any kind of confusion, please tell me. I am ready to repeat it 1,000 times. Now, the another prompt, that is gradual loss of vision. So for gradual loss of vision, the initial questions will be when it started. Did it started suddenly or gradually? And this gradual loss of vision is occurring for the first time, or is it occurring many times earlier? So is it occurring for the first time in the life? Then also, does it affect one eye or both eye? For sudden loss of vision and gradual loss of vision, for both these cases, we have to identify whether this is affecting one eye or affecting both eye. Now let's come to the differential diagnosis. There are multiple differential diagnoses. You don't have to remember all of them. I'm telling you what are the important differential diagnoses that are important for PCS exam. One is cataract, diabetic eye disease, hypertensive eye disease, then retinitis pigmentosa, and result-treated retinopathy. There are many causes of gradual loss of vision, like cataract, diabetes eye disease, diabetic eye disease, hypertensive eye disease, macular degeneration, clinically significant macular edema, retinitis pigmentosa, laser-treated retinopathy, and optic atrophy. To remember the cause of optic atrophy, there is a fun mnemonic that mandarin toxin. But believe me, in last 3.5 years, I have never seen any case coming with the prompt of gradual loss of vision where the diagnosis was optic atrophy. I have never found myself. It can come. So you can keep a note of the causes of optic atrophy, but if you ask me, I'll suggest it, don't put much pressure on your brain. Rather, there are many important things to cover it. Because optic atrophy has, up to now, I have never seen any prompt coming with the prompt of gradual loss of vision. So what are the important causes for the PCS exam? The important causes are, one is cataract, then diabetic eye disease, hypertensive eye disease, retinitis pigmentosa, and laser-treated retinopathy. These are the very much important causes. And this diabetic eye disease, hypertensive eye disease, this has come multiple times in the PCS exam. And for these cases, we have to identify, we have to know how to do the fundus, how to examine the retina, how to examine the, how to do the fundoscopy. This is a must to do for every candidate. Before going for the exam, we have to practice fundoscopy. Because in recent scenario, at every center, they keep some fundoscopic cases. So we have to know how to do the fundoscopy, how to identify the changes in the retina. And for this fundoscopy, I will keep some variable hints. One is that during doing the fundoscopy, please practice not to put the hand over the patient's head. Because if by unintentionally or by some reflex, we keep our non-dominant hand over the patient head to make him fix, you lose your mark in the maintaining patient welfare. Because any unnecessary touch is strictly prohibited in the PCS exam. Every time you touch the patient, please take permission. Sorry, I'm going to touch your face. Is that okay with you? For palpating the trachea, I have to take the permission. I'm sorry, I need to feel your wind pipe. Is that okay with you? So this is also same. Whenever we are examining the fundus, please never touch the patient's head. And we have to practice it frequently before going to the exam. And also another thing is that we don't have to identify the stage of retinopathy, that it is stage 1 diabetic retinopathy or stage 2 or stage 3 or stage 4. It is never needed. We just have to identify whether there is hard exudate, whether there is soft exudate, and whether there is bleeding spot. Please keep it in mind. These are very much simple. In the native exam, we practice to identify the stage of diabetic retinopathy. But in the PCS exam, it is never ever needed. We just have to identify whether there is hard exudate, whether there is soft exudate, whether there is any bleeding spot. This bleeding spot can be in the flame shape, or this can be in a blot and dot bleeding spot. We just have to tell, I have identified some bleeding spot. We don't have to identify the arteriovenous snipping, the silver wiring, anything like that. It is not needed in the PCS exam. The examiner will ask you, what are the positive physical findings? Whether you are able to identify the hard exudate, soft exudate, or bleeding spot. That is enough. Please keep it in mind. Then another important differential diagnosis is retinitis pigmentosa and laser-treated retinopathy. It has come at the Pondicherry in this year, first date. So let me give you a clue. So what happens in retinitis pigmentosa? In retinitis pigmentosa, this is the retina. There happens a pigmentation at the peripheral part of the retina. So the patient has night blindness and tunnel vision. And in case of retinitis, in case of laser-treated retinopathy, also the laser treatment is done at the peripheral part. So why I am telling this? Whenever any patient tells you that I am having tunnel vision and also loss of night vision, I am again telling I am having tunnel vision, that I am not able to see the sides, and also I am having a loss of night vision. It is either retinitis pigmentosa or laser-treated retinopathy. Sometimes that you are not able to identify the bony spicules that is found in retinitis pigmentosa. But anytime any patient complains you of tunnel vision and loss of night vision, it is 100% time either due to retinitis pigmentosa or due to laser-treated retinopathy. Even sometimes you may not be able to identify the retinal finding or the fundoscopic finding. But if you know the clue, if you know this clue, you will be able to get the diagnosis. In case of retinitis pigmentosa, the patient will be younger. In case of laser-treated retinopathy, the patient will be old and he will have past medical history of long-term diabetes. Also, if you specifically ask any procedure inside your eye, he will give you the answer. So this is that much simple. It is not necessary that you are being able to identify the fundoscopic changes. If you know this trick, that tunnel vision and loss of night vision, there are two differential diagnoses: retinitis pigmentosa and laser-treated retinopathy. Please tell me if this conception is clear to all, because these cases come in the Pondicherry. Dr. Partho, are you getting it? Is it clear to you?
Yes, brother.
Okay. Dr. Raisa, is it clear to you?
Yes. If the examiner asks what is the finding of laser-treated retinopathy in fundoscopy, what should I tell?
You have to tell, like, I'm finding some spicules. Some
This also
not,
will find spicules.
no, sorry, it will be not spicules. It will be laser. It will be like some laser mark at the peripheral part of the retina. You can tell like this.
Okay.
Some mark of laser treatment. Also, I have to give you something news that what happens in the basis exam, that happens at the Pondicherry. That case was kept in carousel 1 and carousel 2. So the pupil was dilated. Dilated medication was given before the start of the carousel 1. But after the end of the carousel 1, the pupil started to constrict. So whatever the candidates who appeared who got that case in the second carousel, they got some mid-dilated pupil. And it was really difficult to get the findings from this mid-dilated pupil. Are you getting it, Dr. Raisa? This can happen sometimes in the basis exam. So regarding, so this is the clue that whenever the candidate asking the what beings he had today, the surrogate typically replied that I don't see the side, I have tunnel vision, and I also have loss of night vision. Also, I have difficulty in recognizing the color. So whenever the bony spicules tends to progress inward, it can also affect the color vision. We have to remember that. That patient also having some color vision. Whenever the bony spicules tends to progress from periphery to the center, the patient can complain of loss of color vision. And we have to know how to check the color vision. At that exam, the candidate were offered the Ishihara chart and the color vision chart. We have to know how to interpret the Ishihara chart. Are you getting it, Dr. Partho?
Yes, brother.
Okay. And regarding the laser-treated retinopathy, in the PCS exam, it is not needed that you describe the findings in proper way. Like, they'll see whether you're able to identify the findings. You can tell like that I am getting some laser treatment mark at the peripheral part of the retina. And in the past medical history, the patient will typically give you the history that I am a long-term diabetic patient and I had some procedure inside my eye. This is, up to now, I have never seen any case coming that, but retinitis pigmentosa is important. Retinitis pigmentosa has come sometimes. And this year it has come in the Pondicherry. And this case is there. This case can again be given for the Pondicherry candidates. And also, retinitis pigmentosa will not be given alone. This will be given as a part of other syndrome. So what are there are some syndrome. They are Usher syndrome, Kahn-Sierre syndrome, Rapsam disease, Bardet-Biedl syndrome, beta lipoproteinemia, and Alport syndrome. The case that was given in the Pondicherry, the prompt was patient was having vision problem and walking difficulty. And the candidates were not able to identify any syndrome. The candidate was able, in fact, to identify the bony spicules and able to say that this is a case of retinitis pigmentosa. All of them got full mark. So just to keep in mind this syndrome, if you are asked, so how to identify each syndrome? In Usher syndrome, apart from retinitis pigmentosa, the patient can have some hearing problem and ataxia, that is walking difficulty. So that case could be Usher syndrome. I am not sure what was the case there. In Nerson disease, apart from retinitis pigmentosa, the patient will have peripheral neuropathy and short for metatarsalophalangeal metatarsal. In case of Bardet-Biedl syndrome, typically the patient will be obese. Just keep it in mind. In beta lipoproteinemia, apart from retinitis pigmentosa, the patient will keep complaining of loose motion. Also, ataxia can be there. In case of Alport syndrome, apart from retinitis pigmentosa, the patient will have hematuria. In Kahn-Sierre syndrome, along with retinitis pigmentosa, the patient will have complex ophthalmoplegia. That is, he will have double vision in all directions. This is not a PACES case, and this will never be given. But if the examiner asks you, do you know any other any symptoms that can be associated with retinitis pigmentosa, you can utter the name of this syndrome. If there is time left, you can give some clue that what are the points that goes in favor or in against this diagnosis. This is something like that. So please tell me if there is any question from this prompt. Anyone has any kind of question? Dr. Brevis, do you have any question from this prompt?
No, sir, fine.
Okay. Dr. Raisa, do you have any question?
No.
Okay. Dr. Nozrul, any question from this prompt?
No, sir. Thank you.
Okay. So I will request you to practice the fundoscopy and practice it without touching the patient's head, and try to identify only the hard exudate, soft exudate, and bleeding spot. It is not necessary to identify the stage of retinopathy. Believe me, it will create extra pressure inside your head. In the PACES exam, they don't want the stage of diabetic retinopathy or hypertensive retinopathy. They just want to hear whether I am able to identify the hard exudate, soft exudate, or bleeding spot. So this is all for this prompt. Now let me progress to the next prompt. This is all the transient weakness. This is also triple ester prompt, because I have told you for PACES exam, TIA and aminosis feedbacks are very much common prompt. These are one of the two of the most favorite prompts for PACES exam. They gave it every now and then, and this will be typically a dummy case. So how to approach to this prompt? We have to ask, when did it occur? Did it occur suddenly or gradually? Then is it the first time? Then this transient weakness, we have to identify, did it affect only the hand or hand and leg both? Any deviation of mouth? Because in the PACES exam, sometimes this prompt can be given only by hand weakness. No leg weakness, no mouth deviation. Only by transient weakness of the hand. This has come, and this has come also this day in the Dhaka Center. The prompt was, the patient, she was a lady, she had a past medical history of mitral stenosis, she had transient weakness of the hand. And this was a case of TIA, that is transient ischemic attack. So we have to ask which part of the body it affected. Did it affect only hand or hand and leg both? And was there any deviation of the mouth during that episode? And like any other symptom, any transient weakness, we have to ask before, during, and after. We have to ask, what were you doing before this episode? For how long the symptom lasted, and how did you get back to normal? Because only for I have seen a feedback from the Bangalore. It was 1.5 years back. The candidate didn't ask this before, during, and after question for this transient weakness. This was a TI case, and the examiner cut his mark in the clinical communication skill. So that is why any transient weakness, any transient symptom in the basis exam, please ask the before, during, and after question. So now, what will be the differential diagnosis that is important for the basis exam for this transient weakness? They are TIA, hypoglycemia, migraine, and multiple sclerosis. Seizure is not important. That is Todd's paralysis. It is not that much important. It has not come up now. So how to rule it out? For TIA, typically in the past medical history, the patient will have some risk factor, sometimes with only hypertension. For hypoglycemia, we are ruling it out by asking, how did you get back to normal? For migraine, we have to ask, do you have any headache? Or where the weakness were preceded by any headache? That is hemiplegic migraine. Then for multiple sclerosis, we have to ask, any similar episode of weakness before? So that is that screening question for the differential diagnosis. And for any case of weakness, transient weakness or TIA, we have to stop the driving till further assessment. No need to tell the patient for how long you have to stop the driving. We have to just save our back by telling the patient that stop driving till further assessment. Because this is not the last time we are having meeting with the patient in the real life, in the UK center. In the UK, whenever we are practicing in the UK, this is not the last time. We are taking history, then some investigation will be ordered, and after the investigation reports have come, we have to sit with the patients again. So we can save our back for any prompt whenever we are not sure that we have to stop the driving or not. We can tell the patient that stop driving till further assessment. And as the patient was having weakness of the hand and feet, we have to assess the gait if there is leg weakness. And we have to assess the functional capacity of hand if there is hand weakness. Please keep it in mind. Now let me ask you a question. Suppose the case is hemiplegic migraine and she is a middle-aged lady and she is taking oral contraceptive pill. So what will be the important safety netting here?
OCP will be stopped and we need to refer to woman doctor.
Yes, doctor. We have to tell the patient that stop the birth controlling pill and I am referring you to the woman doctor to offer you a safer alternative. So this is all for transient weakness. I'm again telling, don't forget to examine this part because from my experience, I say that this is the thing that many of the candidates forget to examine. And this is the complication. Whenever anyone is having any problem with his lower limb, we have to check the gait. This can be weakness, transient weakness, or permanent weakness. Whenever anyone is having some problem at the hand, this problem can be hand pain. This problem can be transient weakness. This problem can be hand tremor. We have to check the functional capacities of hand. If we don't check the functional capacities of hand, we will lose our mark in the physical examination section. So please ask me if there is any question from this prompt. So please let me ask one by one.
Sir, can you repeat that question of this thing referring to the woman doctor? I just missed that question.
Okay, no problem, doctor. Whenever in any scenario, we have to stop the OCP, we have to tell the patient that stop the birth controlling pill and I am referring you to the woman doctor to offer you with some safer alternative.
Sir, about the migraine thing you were asking.
Yeah. In case of hemiplegic migraine, if the patient continues to take the oral contraceptive pill, that will increase the cardiovascular risk of having any cardiovascular accident like heart attack or brain stroke.
Okay, sir.
That is why it is important to stop taking the OCP.
All right.
All the cases has come in the basis exam. TI has come, hypoglycemia will automatically become the differential diagnosis. Hemiplegic migraine has come, multiple sclerosis has come. With only in the recent Mumbai, it has come, the multiple sclerosis, the prompt was transient weakness. And in the past medical history, the patient was having recurrent episode of weakness. And also, she was also having some cerebral fracture. This case was given last year in the Mumbai center. Seizure has not come up to now, but you can keep in mind. Whenever there is a seizure, there can be, after the seizure is gone, there can be TOTS paralysis. It is post-ictal paralysis. After seizure, the patient can have some symptoms of hemiplegia or quadriplegia can be there. It is called TOTS paralysis. So this is all called transient weakness. Now let me process to the last prompt or to this session. That is tremor or shakiness of hand. So this prompt can be given to you from outside with a prompt like, this patient has come to you with the complaint of hand shakiness. Please talk to him, examine him, and meet his concern. So how to approach to a case of tremor or shakiness of hand? Our first question will be, the complaint is shakiness of hand. So we have to ask, apart from this hand shakiness, if there is any other body parts affected, like the legs, like the head, like the voice, because sometimes there are some other body part affected, like in case of essential tremor, you'll say that the head is nodding. In case of essential tremor, also there can be voice tremor. So we have to identify if there is any other body parts affected. Then the next question will be, does it occur during rest or during some movement? To differentiate resting tremor from working tremor or intention tremor. Then the third question will be, any change in handwriting? Why this is important? Because in case of essential tremor, the handwriting will become bigger. As the symptom progresses, the handwriting will become enlarged. But in case of Parkinson's disease, patient will have micrographia, that is smaller handwriting. So these are the three initial questions for tremor or hand shakiness. Then we have to analyze the symptom using the mnemonic ODPARA. I hope this is already clear to everyone. What does ODPARA mean? O means onset, D means duration, I means initial episode, P means progression, A and R goes for aggravating factor and relieving factor. Now let's progress to the differential diagnosis. For the differential diagnosis, you can keep your mind this picture. That is, end your liver with anxiety, alcohol, and coffee. These are actually the differential diagnosis of tremor. So what goes for end? Here, N goes for E for endocrine cause, N goes for neurological cause, and D goes for drug-related cause. So what are the endocrine causes of hand shakiness or tremor? They are hyperthyroidism and hypoglycemia. Then neurological causes are there. They are most important. They are essential tremor, Parkinson disease tremor. This is most important because this comes very often in the basis exam. I have already explained to you how the cases come. At one carousel, they will keep it at the short case station, and at another day, another carousel, they will keep keep this case as the prompt of hand shakiness of tremor. Then another cause is cerebral tremor, and this cerebral tremor can be one-sided or both-sided. How to rule it out? I will give you the screening question, and what will be the differential diagnosis for unilateral cerebral tremor and bilateral cerebral tremor? I will tell you the mnemonic. Then there are some drug-related causes like beta agonist, lithium, cyclosporin, and tacrolimus. All the cases has come in the basis exam. Like the beta agonist, the cases was there. The patient is having asthma, recent asthma exacerbation, and he's taking the brown inhaler, the blue inhaler. In the basis exam, they will not tell you that salbutamol inhaler and steroid inhaler. They will not give you the information like that. They will tell you either blue inhaler and the brown inhaler. But keep in mind that the blue inhaler is the salbutamol inhaler, and the brown inhaler is the steroid inhaler. So in the history, the patient will tell you that recently some increased episode of breathlessness, I am taking the blue inhaler in more frequently. So this is due to some beta agonist induced tremor. Then lithium can also cause tremor. Cyclosporine can cause tremor. In the lithium, in the past medical history, the patient will give you history of bipolar mood disorder. Cyclosporine and tacrolimus can cause tremor, and this cyclosporine and tacrolimus can be given in the PCS exam because these medication are given in the renal transplant. So any renal transplant patient that is kept for the short case station in the abdomen, that can be switched over at the next catheter with the prompt of hand tremor. Please keep it in mind. And also this is very much important for Chennai because Chennai is all of renal cases. Then liver-related causes, if you remember end, then liver, end, you liver. Liver-related causes is Wilson disease. We have to look at the past medical family history. I'll tell you what will be the screening question later on. Then anxiety, alcohol, and coffee. Anxiety can cause some tremor. Alcohol withdrawal can cause some tremor. And coffee intake, excessive coffee intake can cause some tremor. So right now, what I want to tell you is that what I have noticed that most of the time, most of the candidates are able to rule out all the important differential diagnoses, except two simplest one, that is anxiety and coffee. They forget to exclude whether the patient is having excess anxiety or whether the patient is taking excessive amount of coffee. These are the two simplest ones that the candidates forget to ask. So what will be the screening question? For hyperthyroidism, we have to ask about the weather preference. For hypoglycemia, we have to ask that did you measure your blood sugar at that time? And in the past medical history, we have to keep in mind, we have to check whether there is any history of taking insulin in the drug history. That can cause some hypoglycemia. Or in the drug history, the patient can give you history of taking oral hypoglycemic agent like sulfonylurea. So you will get some clue in the past medical history and drug history. For the neurological causes, it can be essential tremor. It will be there will be typical family history causes, like it is autosomal dominant case. So the patient will have similar affection in the father or mother, and it will be clearly evident by seeing the patient. The patient will have head nodding. For Parkinson's disease, the screening question will be: do you think you are getting slower day by day? This will be the initial screening question for Parkinson's disease. Please keep it in mind. If the patient tells you that, yes, I am getting slower day by day, then you can assume that this is a case of Parkinson's disease. After that, you can ask all the other symptoms of Parkinson's disease. I will tell you what are the other symptoms of Parkinson's disease. That is also rule of D. I'm going to tell you the later part of this session. Then cerebellar tremor can be there. What will be the screening question for cerebellar tremor? The screening question will be any balance problem. In the PCS exam, any balance problem, this is cerebellar affection. Then the next question will be on which side, one side or both sides. If this is one side, then this is unilateral cerebellar affection. If the patient tends to fall on both sides, then this is bilateral cerebellar affection. For unilateral cerebellar affection, the mnemonic is STD, sexually transmitted disease. Here the S goes for stroke, T goes for tumor, and D goes for demyelination of the multiple sclerosis. This goes for STD. If the patient has a problem in balance and he has tendency to fall on both sides, the mnemonic is my alcohol can drive gene. Here my goes for multiple sclerosis, alcohol goes for alcohol, can goes for cancer. We all know that there are some paraneoplastic syndrome where the patient can have bilateral cerebellar syndrome. Drive goes for drugs. For PCS exam, there are two drugs. One is phenytoin. Another one is lithium. These are the drugs that can cause bilateral cerebellar affection for any patient. Then gene goes for genetic disease, that is Friedreich ataxia. For PESIS exam, multiple sclerosis, alcohol, and drug causes are important. Cancer and genetic disease, that is Friedreich ataxia, have not been given up to now. And also for unilateral cerebellar tremor, both STD, these three are important. So this is a screening question for cerebellar tremor. Now there are some drug-related causes. These will be evident from the drug history. To rule out the liver disease, that is Wilson disease, we have to ask about the family history. That any family history of liver disease. There can be past medical history of liver disease, or there can be family history of liver disease. In case of Wilson disease, we can rule it out by asking any personal history of liver disease or any family history of liver disease. Because Wilson disease patient will have some liver affection. Please keep it in mind. Then anxiety, we have to ask about what about your mood. For alcohol, if there's any binge alcohol drinking or sudden alcohol withdrawal, it can be there, but it is not important for Indian center. It's important for UK center. And also for the coffee, we have to ask, do you take excess amount of coffee? So this is all for handshaking and tremor. And also never forget to assess the functional capacities of hand for any case of tremor. Please don't forget it. And for any case of tremor, whatever the causes, please examine for thyroid swelling. Because by examining the thyroid swelling, you are showing the examiner that you are ruling out hyperthyroidism, that is Graves' disease. Please keep it in mind. So now let me tell you the symptoms of Parkinson's disease. That is also rule of D. If we start from the head, first is dementia, then depression, then dysphagia. In advanced Parkinson's disease, the patient can have some dysphagia. Then dizziness. This dizziness is due to the postural hypertension. In advanced Parkinson's disease, due to autonomic neuropathy, the patient can have postural hypertension that causes dizziness. Then daytime somnolence. Due to some medication effect, the patient can have daytime somnolence. This occurs especially due to the dopamine agonist. And last, the erectile dysfunction. That is problem in intimate relationship. So you can use this mnemonic, that is also the rule of D, to remember the features of Parkinson's disease. And what are the examination you have to do for each cases. This is explained in detail in the section of the physical examination video that I will provide you tonight. So this is all for handshakiness and tremor. Please keep in mind, this is also a triple ester case, and this is very much important case. And what is the most important one? That most of the maximum candidate forget to take the history of anxiety and coffee. They take history all the other things, but maximum time they forget the simplest thing, that is anxiety and coffee. So please ask me if there is any question from this prompt. And this is the last prompt for today's session.
Doctor, for the tremor,
Yes.
in endocrine section, can we keep pheochromocytoma as it can also present with tremor?
Yes,
Or
it can come, but up to now I have not seen this case coming with the prompt of tremor. It can occur, but I am telling from the 3.5 year experience, doctor.
Okay.
Any other question?
Brother, can you please show the slides for this non-motor symptoms of Parkinson's again?
Yes, doctor. This is also the rule of D. From the head, we have to rule out dementia. Advanced Parkinson's disease can have dementia. Patient can have depression. We have to ask, what about your mood? In advanced Parkinson's disease, patient can have oropharyngeal dysphagia. We have to ask about the swallowing difficulty. Then, in advanced Parkinson's, patient can have postural hypertension resulting in dizziness. Also, due to some medication effect, patient can have daytime somnolence. That patient will feel dizzy the whole day. And last, there will be erectile dysfunction. That is problem in intimate relationship. And the screening question will be, do you think you are getting slower day by day? It is actually the screening question. For every differential diagnosis, I'm giving you some screening question. So whenever, by asking the screening question, you are getting it positive, after that, you have to enter into all the other symptoms of that differential diagnosis, unless not necessary. Is it clear, Dr. Partho?
Yes, brother.
Okay. Any other question from any other candidates? Dr. Anwar, do you have any question?
No, sir.
Okay. So if there is no question left, then I'll take this, like to take some break of 20 minutes. So what I'll do now, after this session is ended, you will get the access to these neuro cases. There are 32 cases from these 5 prompts. These are some real cases scenarios. So everything needed is written in details here. That is possible. So along with the picture, and also with a separate drive link, you will get the link to the physical examination video. Is there? Yeah, it is there. This is a physical examination. And by seeing the physical examination and the prompt, you have to take your preparation. You will get the access by another link. So that's all for today. So I'd like to take a break of 20 minutes. After that, I will come back again with the practice session, because during the last session, I have provided some 31 cases to the active candidates, and they have to take preparation for that prompts. And I have to see how the candidates have practiced. So right now I'm going to switch off this link. I will provide another link 20 minutes later, because if I stop this link here, I will get the recording within 2 hours, so that I will be able to keep the recording within 2 nights. That is why I will stop this link and I will provide another link within 20 minutes. That will be due to the practice. And I also post it in the main group. Everybody will be able to see how the practice is done during our active session. I hope this is clear to all. Again, please ask me if there is any question from any candidates before I stop this session, because I have to close this Zoom link and I will keep another Zoom link for the practice session. Okay, I hope everything is clear to everyone. Now this is the time to take preparation before the next session. So I'm closing this Zoom link and I'll give another link for the practice session, and everybody is invited to join this practice session. Goodbye all. See you later within 20 minutes.